Assalamu alaikum, ladies and gentlemen. Welcome to CxO Global Forum show on health tech. Health is wealth. The CxO Global Forum is Pakistan's largest C-level forum involving some of the biggest names in their respective industries, working at the height of Pakistan's economic recovery and bolstering in their respective industries where need be. So the topic today is a very pertinent topic to not just people living in Pakistan, but people around the world. And this topic has to do with the COVID outbreak that has taken us into conditions we could never have imagined over the past year and a half. We have seen economies collapsing, we have seen industries being torn apart, big companies being brought down to their knees overnight, people's lifestyles changing at the flick of a button, and many lives lost, some of which are very dear to, I'm sure, people in the audience and both of us. For me, it was family members and a few key friends. So before I'd like to get started, let's just take 10 seconds of silence to honor those who have perished in the wake of this pandemic. Before I'd like to get started, let's just take 10 seconds of silence to honor those who have perished in the wake of this pandemic. Thank you all. I'd like to introduce my guest today, who is Dr. Rana Jawad Askar, describes himself as an epidemiologist and a keen observer of public health systems worldwide. So, Assalamu alaikum, Dr. Saab. Hope you're doing well. Hello? 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 We're experiencing some technical difficulties right now. Hello?
आवाज आ रही है आपको कि नहीं आ रही?
अब आ रही है जी. How do you do?
Okay.
So thank you very much for joining us on the show, Dr. Rana. So just to give a brief introduction about our guest, he is an epidemiologist by profession and a keen observer of public health systems worldwide. So my first question to you naturally is how you got so immersed into studying about epidemiology and what generally has fascinated you about public health systems in general. So before I officially give the floor over to him, I think it's worthy to note that we have, as a country, produced one shining example of someone who contributed very, very heavily to America's public health system, especially in the case of public safety and transportation, and that was Dr. Umayya, who also was known for creating the Umayya Reservoir, which is still used in neurology to this day. So over to you now.
Thank you very much. It's an honor to be on this forum. I entered into the area of public health actually much earlier than entering into epidemiology. Even in a medical student, as a medical student in Lahore, very early age, I set up a health education society, which basically tried to improve the health of our population at a very little scale. But at that time, it was one of the most active welfare, public health welfare student societies of its time. And it arranged many seminars, published many booklets on public health. So that's how I entered into the area of public health field. And then, I won a University of Bristol scholarship in England, and I studied there for a year again in epidemiology. So that was my first interaction with hardcore epidemiology in that 1 year of postgraduate studies at University of Bristol, and then I liked the field. I became interested into it, and then I formally applied for masters at University of Washington, got admitted there, and from there I also got the fellowship in emerging infectious diseases. So that it was the I was like set in public health and epidemiology, and from there moved to Stanford University again in US, and then from there to London School of Hygiene and Tropical Medicine as a faculty. So, and then went to Africa. Then actually, back in 2004, I was selected as a epidemic intelligence service officer, what we call EIS, and that's one of the premium public health program, where for last 70 years, US CDC was preparing public health graduates to manage outbreaks, epidemics, and possible a pandemic. And in that 70 years of the history until today, we are 6 Pakistanis who were selected in these programs in last 70 years. And when I got selected, I was the 4th Pakistani. But out of 6 Pakistani, I'm only one Pakistani who is now living and working in Pakistan. And that gave me also an opportunity to set up public health programs in Pakistan, one of the finest sister program of US CDC program. And through that program, a lot of Pakistani doctors, public health professionals actually won highly competitive international prizes, positions, again in public health and epidemiology. So I think it started, you could say, by chance, because I applied for a scholarship program. Public health, I had the seats in me, but the epidemiology started as by chance that I got selected for, again, a very competitive scholarship of University of Bristol, and where first time I was exposed to what epidemiology is. And I should remind our viewers that at that time in Pakistan, hardcore epidemiology was not taught in medical colleges or anywhere. It was more like hygiene, like how to construct, which is again part of public health, but it was not the epidemiology. So that's the full circle of my learning, my getting into epidemiology. So sorry, answer got a little long, but I thought I should give you the flavor of the whole thing.
No,
Yes.
that's very, very good to know that you ended up becoming quite distinguished in your field. It was something that interested you from a young age, and then you ended up coming back to Pakistan and sharing your knowledge for the greater good of our nation. So I tip my hat off to you for that. The second question is that you have been quite active in writing about infectious disease, namely the different COVID variants. Whenever I see you spreading on even WhatsApp the different articles that you come out with. So it's clear that you're positioning yourself as a very well-reputed key opinion leader in healthcare. But I wanted to ask, what is so unique about COVID-19 in general? Do we see any shades from the Spanish flu pandemic in the 1900s? What's relatively better about COVID, and what's
So
worse about COVID, comparing the two together?
yes. So the reason it is so fascinating that for last 100 years, public health professionals like me were worried about the next pandemic. Globally, some major countries in later years realized that danger. For us who were in the field, it was not the matter of when, if. Our major question was when. And if you just look at few years before the pandemic, most of the public health professionals were really worried. And we were worried for a couple of reasons. The international travel which basically mixes different population at a high speed, had gone to huge level. I can't remember, like, but any given time, there were 30,000 daily flights, international passenger flights, commercial flights. We are not talking about the army planes flying and everything. So and then the whole goods, created from, let's say, Africa or produced in Africa were coming to US and everywhere else at a very phenomenal speed. And when this huge mixing was happening, we had one of the huge, again, population index going up. People are mixing. There is more people are living per square mile in this globe. And these things basically were telling us that anytime a new pandemic could start. My own paper was published just like in December 2019, when the pandemic had already started and we didn't know about it, in which I actually looked with my co-authors, looked at pandemic preparedness level and how people are measuring it, and we raised very serious questions about it. And what we wrote in that paper, which was published by John Hopkins University paper or journal, and we said the world is not ready, and even the rich countries which are thinking they are ready, they're gonna fare badly. And we gave the all those reasons. We talked about the challenge of variants, possibility of variants, and how rich countries won't be able to stop a variant entering into their borders. There's no way you can stop. So so the point I'm saying is, this is something we were dreading, and then it came, and then it came, and it spread so quickly. And I remember that on 15th of January, I reached out to Pakistan Health Minister of that time, Dr. Zafar Mirza, and I told him, I said, there is a new virus, new disease actually, um, and now few cases of it is in 3 other countries. At that time, outside China, cases were, I think, very few, 10, 15 or so. And we decided that it's time to start thinking about it, and let's bring in experts so we can monitor the situation early. So we were so worried on the 15th of January, and very quickly our core committee was approved, in which me, Dr. Faisal from AKU, and Dr. Faisal Sultan, who is now the current minister, we were the three independent technical experts on that committee. And we tried to, and the system was, as you know, or well imagine how bad the system was, at what stage it is. So at that time, and we didn't know the risk factors. What it was very early days, so we have to come up with defenses without knowing your enemy at that time. So that's how I think the question is. And then I was keeping again myself abreast of every new happening, and that's why if you dig my post or my articles of 2020, early 2020, the ventilation issue I started raising back in April 2020, because it made sense to us as an infectious disease person. And then how the things developed, how
Sorry, we're experiencing a little bit of technical difficulties. A lot of people have been complaining about the internet today. And I think the next question that I actually had was already more or less answered by Dr. Rana, which was how this particular variant COVID-19, SARS became so widespread, because we have to realize that essentially the formal name of COVID-19 is SARS-CoV-2. The first two variants we saw were the original SARS virus and MERS. And SARS essentially only had 10,000 cases with a mortality rate of less than 30%, whereas MERS had around 3,000 cases with a mortality rate of between 60 and 70%. And then we see a disease like SARS being so widespread, being so prominent in different countries around the world, whereas these other diseases were region specific. In the meanwhile, while we try to get the host back, there are some interesting stats I'd like to go over with you. So I'd like to share my screen. And we do have him back. I'm so sorry, Dr. Rana. I did want to skip over the next question because you more or less handled it, which is why this particular SARS variant compared with the actual SARS and MERS was so widespread, and it had to do with travel patterns. And I was actually going to share my screen to share some stats about, how COVID has been. And then we'll go on to the next question. So right now, as you can see, I've done, made some notes, and with Pakistan, the cases, about 1.3 million cases have existed in the entirety of the entire pandemic from around March 2020 to today, with around 28,000 deaths. So you're seeing a 2.2% mortality rate, whereas worldwide, the figures are 264 million cases, which is around 5% of the world's population, with 5.22 million deaths. And I think to keep for later on, because I'm going to be touching more on Omicron specifically, what we do see is the fact that over the past 5 days, we have had an average of 360 cases per day, whereas you compare to the last 6-day period, it's 320. So you're seeing a little bit of a spike in 40 to 50 cases, even though we don't know for sure whether it is Omicron or not. And that spike specifically is happening in Sindh as opposed to other provinces. And just before I go to the next question, I think it's interesting also to note that this is a chart. If you can make it out properly, it gives you the percentage of each variant as time goes by. So from Alpha was the dominant variant up till, you could say, July 2021, and after that, this essential teal color represents the Delta variant, which, even if you look at worldwide stats, had actually more contagious cases, even though one might say the mortality rate was not as high as when Alpha came about. And there's different reasons as to why that might be. I think Dr. Rana can then explain that further on as to whether it's because our healthcare systems improved, whether the variant itself, had been combated due to improved immunity. So I think that pretty much brings us to our next question, Dr. Rana, that how essentially has Pakistan handled the pandemic? And how do you compare it with the way other countries have handled the pandemic in general? Sorry, Dr. Rana, could you try taking your camera off and speaking to the mic again? Hello? Apologize once again, experiencing another technical difficulty. So essentially, through another talk that I had with the Dean of the Health Sciences Academy, Dr. Shahzad Khan, he mentioned that we had a healthcare system that was ranked 120 globally before the pandemic hit. And because of the pandemic, because of the way we acted under such adversity, we ended up being in the top 10 health systems worldwide. It had to do with the fact that we wanted to contain the population in urban areas. We ultimately recognized that this was a disease that was being carried forth by people traveling from outside of Pakistan and coming back in. So that was one measure that was taken. Another measure that was taken by the public health system was essentially to increase the number of beds in every hospital there. Yes, like he mentioned, ventilators were heavily stressed upon. A lot of key players in different elements of healthcare were also called to bring in ventilators over there. So glad to have you back again, Dr. Rana. Can you try speaking? Um, so
Yes.
how has Pakistan
Yes.
handled the
So the
pandemic?
question, so it's between, Pakistan has not been a rock star, and Pakistan has also not failed in response. So the answer is like in the middle. When people says Pakistan, and one thing I mentioned that we started well, and so before the first patient was discovered in Pakistan, we were already trying to strengthen our system for last 5 6 weeks. So that was a head start. Then, NCOC came later, which provided the muscle to the decision making. Before, no one was listening to the Ministry of Health. No one cared about it. So, and that implementing those orders was difficult. But when you bring in, the uniformed people, people listen, and that's what happened. So these were a couple of good things. The bad things which happened, and one of the bad thing is that we still don't have good quality number of disease in our country. You just mentioned, the mortality rate, and as you said, it is 2.2 or something. And if you looked at Pakistan death rate over last 2 years, it is a straight line of 2.2. In real life, that does not happen like this. That shows, that indicators to me shows that data is not right, and someone is, keeping it in a straight line. And if you compare with other countries, their mortality rates, they goes up and down. Actually, in the beginning they were up, and the later they brought down it significantly. But I think we are one of the unique countries. In a straight line, we have our death rates, and that basically shows suspicion on the quality of data which they are being collected. Second bad thing which happened was that in the beginning, when people were worried, we started sending police, intelligence agency people to cases houses, their contact houses. There were very public news about how the families were separated and they were sent to different camps, especially in Punjab, that happened. And that created a fear. And that fear is still today, that when doctors, and I'm sure many of your colleagues will be doctors, even 2 years after the pandemic, when they tell them to go and get a COVID-19 test, many of the patients refuse to get COVID-19 test. And they tell doctor, we are ready for HRCT or other tests, but we don't want to be named. So the stigma got attached with the testing, and these two things basically compromised our health intelligence. And fighting a war with a virus or a bacteria is like fighting a war. And if you do not have a good quality intelligence, your countermeasures are then planned in vacuum. Sometimes they work, sometimes they don't work. So I think that was the weakest link. Otherwise, and the one major reason for which we didn't have that number of deaths is because our population in Pakistan was younger population. Even our population is on average younger than Indian population. That's not something to good think, be happy about. Actually, that means that the life expectancy in our country is really poor. So only 4% of our population, less than 4%, lives above 65 years of age. Compare it with the European countries or America, that's 25% of their population lives above 65 years of age. If nothing else, That only on its own meant that they could have 5 times more death, but still equal to our
But
country. So I
statistically
think,
speaking, that's under a control that the same diseases exist over there as they exist in Pakistan, right? Or is that also not taken into account? Or is that different?
sorry, I missed your first part. What you said?
So the first part is right when you talk about how there's, Pakistan itself is not a longevity hotspot. You have higher longevity in places like, say, Japan, and Sardinia is also a longevity hotspot. Are you saying that it's because of our environment that we also have different types of diseases or different manifestations of diseases, and those other countries don't? Or is it to do
No,
with other sort of facts like diet and
no.
environment and whatnot?
The reason we don't live long is because our health system is very weak. Our under 5 years mortality is very high. Our under 1 year infant mortality is one of the highest in the region. So we kill our kids too early. We killed our older population early, and then we have the people who survive are pretty much stubborn, who survive that long, because the whole environment of health system, nutritional system. The Prime Minister, in his inaugural speech, told us that more than 50% of our kids are malnourished. I don't have the exact number, but huge number of them uh, are behind the IQ level which is required for any healthy nation. So it's not just the infectious, and then because we do not have clean water and sanitation, multiple infections make their immune system sometimes weak, and the kids die, and that's why when we come up with the overall life expectancy, it's a very poor number. Yes,
That makes a lot of sense. Yeah.
yes. So now in today's, because of the travel is so fast and so huge, that the old notion, which was that these diseases are common here and less common here, are actually mixing up. Think about dengue. Dengue was like 20, 30 years ago, dengue was only in 7 to 8 countries in Pacific. Now, dengue is prevalent in more than 100 countries. West Nile fever, when came to US, it was, so they were very able, because it was a new disease which entered in the US. So they were able to plot its whole travel, because it started from the airport in the New York to slowly move west until it reaches all parts of the US. So now, because there is so much transport happening, and bugs, insects are taking a ride on that, and actually then go infect those population which were not immune to it before. If a disease stays in a population where it is for centuries, the animals and the humans get a little bit immunity against it, and it does not disturb them that much. But when the disease moves from its original place to a newer place, its devastation is much higher.
Right, that makes a lot of sense completely. It's about not just public health system, but how diseases manifest themselves and how the response is the disease. And right, it's we talk about America. Yes, the response was quick because the systems were developed. They have the CDC. They have all these institutions there, not just complying research, but also trying to protect them from such outbreaks, from taking becoming disasters in its entirety. So I had three follow-up questions, which I'm going to sort of culminate into one because our time is a little short, and these have to do with Omicron. So essentially, tell us what exactly Omicron is, and if you look at what Omicron actually is as a word, it's the 15th letter of the Greek alphabet. We talk about alpha, beta, gamma, and delta. These are the four variants that have existed before. And naturally, delta is a fourth letter, but Omicron is the 15th. So why is it skipped? And okay, I'll sort of answer that, but I'd like you to elaborate on even more, and I'll even share my screen to share some stats. Um, so there were two variants detected between delta and Omicron as lambda and mu, and those were labeled as variants of high interest. Whereas Omicron, like alpha 2 delta, for the previous four, were labeled as areas of high concern. So before I wanted to have you delve into this, I'd like to share my screen again. And I just wanted to, share with everyone the sort of transgression of these variants. And like I mentioned before, right, we see Delta now even taking Pakistan over by storm in terms of the cases detected. And if we go, say, over here, we see that right from December to around May 2021, you had these four prevalent variants, which are all variants of high interest. And then you have Omicron over here. And then in between that, you have Lambda and Mu, which were of high interest, but supposedly didn't do enough damage to be labeled as variants of high concern. So we then see the definition that WHO has come up with, that a variant of interest is a variant with genetic changes that are predicted to known to affect virus characteristics, transmissibility, disease severity, immune escape, diagnostic or therapeutic escape, and that has been identified as causing significant community transmission or multiple COVID-19 clusters in multiple countries with increasing relative prevalence along increasing number of cases over time. Whereas a variant of concern shows an increase in transmissibility or detrimental change in COVID-19 epidemiology, or increase in virulence, or change in clinical disease presentation, or decrease in effectiveness of public health and social measures, or available diagnostics, vaccines, and therapeutics. So I think Dr. Rana, it's your time to shine and give an elaborate answer to these three that I've coupled up together. I've even
So,
shared the questions with you on the chat. Yeah.
so first the question that why we skipped different names and moved to the 15th alphabet. Actually, as you were already mentioning, there are two types. One is a variant of interest and one is variant of concern. So the numbers were already taken, and you may not know about them because they were still variant of interest, but these numbers were taken. Yes, there were two alphabets skipped, not 10 alphabet was not skipped, only two were skipped. And two were the new and Z. And the new, according to WHO, was skipped because that would have implied, people would have implied that it's a new variant, new virus or something. So that's why they skipped. And the Z, because it's a common Chinese name, and they didn't want to, target a population because as if you remember when pandemic started, U.S. president was calling it a Chinese virus, and there was actually a lot of attacks happened on Chinese population around the world. So I think WHO wanted to avoid that. So that's why these two alphabets were skipped, and the next name was Omicron. So what is Omicron? And that's interesting actually. Normally, when we think about our own life cycles, we see there is a grandfather and there is son, your father, and then you, and then your son, and there. That's how the generation starts. And many times that happens, but many times in viruses, multiple variants are developing separately or parallel. So this Omicron is not a continuation of Alpha or continuation of Delta. There are three theories at this time that it's actually more closer to the initial, let's say, virus than the newer variants. And that's puzzling the scientists. And there are three theories or explanations which could be true. One, it was inside a immunocompromised patient. Like, normally people are get rid of virus in 10 days once they get infected, once they have symptoms. But in immunocompromised people, sometimes it stays for 6 months, 7 months, like people who have HIV or other diseases. So the one is that it got the chance to change itself because they were, trying to get rid of it, but it was not working, just like antibiotic resistance happens. So it learned the new tricks inside one human body. That's one theory. Second is that it was circulating in a group of population which we were not aware of. Like there may not be good surveillance, they may not be, they may not be testing well enough. So, but it was circulating in a small group. And third is that that transmission may be was happening on an animal group, and then it spilled over to human, back to human. So these are three different explanations at this time. And why we are worried? We are worried that it has a lot of mutations. The spike protein has, I think, more than 2 dozen mutations. But apart from spike protein, there are similar amount of more mutation on other part of the virus. And why this is important? And this is important that people are worried that because of these mutation, it may not evade the vaccine immunity, like what the immunity you got from vaccines. So it may have learned a trick to bypass that and still infect the people. Third reason of the very initial data which is coming from South Africa is showing that these numbers are increasing. These are very small numbers still. And it is spreading. I think in the morning I checked, there are 22 countries which have already reported Omicron virus on their land. So it's spreading fast, but still there are many unanswered questions. Is it more dangerous? Is it actually gonna evade immunity or not? Because theoretical things are different than actual real life, how the real life these viruses behave, or how the vaccine protection will behave.
Yes, and that was actually the interesting thing because WHO specifies variants of interest and concern, but then some research portals and some websites also talk about variants of consequence. And right now, Omicron is not a variant of consequence because we don't really know that much about the disease, and it hasn't really taken that many people by storm for us to label it as a variant of high consequence. So I'd like to skip over to, I guess, the final question because it has dragged on quite a bit. But then again, it is quite an important topic that I'm sure a lot of people would like to know more about. So I guess the last question, I mean, which is an amalgamation now of like 4 or 5 questions, have to do with technology. So aside from the fact, or aside from the question I'm going to pose about how we can protect ourselves, naturally one will ask, because this show is based on health tech, that about the types of technologies that exist for protection of this, and biotech falls under that, like the mRNA and the viral vector vaccines out there that have been in circulation, like Pfizer and Moderna. Are they going to be good against Omicron? My own field is in telehealth and e-pharmacy, so how can startups in this realm help curtail this disease? What technology needs to be developed, and what are we doing so far as a nation or as a planet to do in terms of developing new medical devices or equipment to help with this disease? And as somebody whose opinion is very well respected in this regard and who knows a lot about this specific topic, what is your message to all of us during this very difficult and scary time?
Let's start with the protection first. Even the Omicron or any other variants or any other virus, respiratory disease virus, which is going to come later, including flu. So these are simple precautions. If you follow, and we are following some bit of it, it will protect us. And number one is wear your mask and avoid crowded places. And if you have to work in office, open your windows, open your doors. Fresh air ventilation. Yeah, fresh air ventilation reduces 18 times. I'm not saying 18%, 18 times the risk of transmission. That's a huge.
That's a huge
it's much
number.
more than even the vaccines. Yes. So if you are meeting anyone outside your house, always wear mask. And then, same thing, don't sneeze on others. If sick, stay home. So basic SOPs, which government is also telling. But what I'm saying is the ventilation is a critical component, and people are not paying enough attention to it.
Definitely.
So
And in terms of masks, right,
yeah.
I'd like to thank
So I'm bringing the
the
tech part also.
Pakistan Clean Air Initiative for actually providing us a lot of data before this talk about how important it is to keep in mind that the actual, COVID virus is less than 0.1 microns in length. So it's even important to get a mask that falls in the PM.3 range, because right now, because the small people are infesting PM 2.5, if there's also a scare of COVID going on as well. That's very important to keep in mind. Now, for the next part, I
Yes.
think we're going to go to
So,
the actual technologies.
yes.
Yes.
Yes. So technology, if you again, because many of your CEOs have offices, big offices in glass windows, they can't even open their windows because how those buildings were built for last 50 years, centrally air conditions. So if you can get rid of those things, that's much better. But if can't, then you need to invest on best filtration, air filtration systems in your buildings or offices, and these are the HEPA filters, which filter out these viruses. So you have to come up with those and invest on these technology. Then after the pandemic started, I'm using video conference. I think before maybe you were not born there, but back in 90s, I was in US studying, and I had friends who are very tech savvy, and we in Pakistan, we used to have the phone line connections for internet, very slow and slow modems, but still we had, because not many people were using internet. This was my routine to do a video call to my family on a daily basis in 96, 97. So, but seeing this technology now leap forward and basically became a lifesaver for many professions. Since the start of before pandemic, I used to travel internationally hugely. Not anymore, but I'm doing the same kind of work. I'm teaching classes, I'm running workshops all around the world, again using this type of technology. And this technology is not now stayed within just showing video and audio, as you well know. I can do a lot of work, a very participatory work with people spread all over the world, and run different conferences, trainings, I think very nicely. So that has developed, and this will be improved. So when I was living in US, at that time, even the governments took it so seriously, the risk of pandemic, that they were used to have actual exercises of work from home. We we neglected that preparation part, and maybe now with the tech tools, we need to set up our ministries, our key organizations, that they can survive if a future pandemic come, or not. Similarly, the treatment component, what we call e-medicine, that has developed very significantly, and maybe it will go more ahead. I was surprised recently to see that you can set up an online appointment with any physician or any consultant, both in Lahore and in Islamabad, and there is systems which are working now, and very well-known doctors are participating in it. And then our kids' education, while the lockdown was. So in that pandemic time, we tested many of those technologies which were already present for 10, 20 years. And now this is time to, make them even better, and make them, and that, because that will be the new chapter in the tech industry, how to come up with the systems which are better than before. And also, I don't think people will go back to the life which was before COVID-19. Professionally, I'm talking about, many of the business travel will be curtailed. Many of the, and these in-person meetings will shift to the online conversation. So I think things have changed. And if our tech company can identify those, their expertise, and exploit those new opportunities, and there are huge opportunities, I think that will be good for them and us also.
Thank you very much for that, message, and that insight on what we can do better and what we're already doing. That's putting us on the right track to making sure people feel safe and can at least get some level of treatment, or advice while sitting at home, and minimizing mobility among people to further curtail disease. So thank you very much, Dr. Rana, for joining in. Thank you, CxO,
My
for
pleasure.
hosting yet again a wonderful show. And thank you to all who tuned in. And hopefully, I'll see you next week. Thank you. Allah Hafiz.
Thank you. Thank you very much.
All right.